Hello, hello everyone, I'm Liam Stapleton, a podiatrist and specialist in podiatric sports medicine, and I'm here today to answer some questions from the internet. At RunnerJess23 asked, I've been training for my first marathon and my Achilles feels tight every morning. Is it just normal stiffness or is it early sign of tendinopathy? Well, it could be either. So we know that one of the first signs you can suffer with from Achilles tendinopathy is morning stiffness, and often one of the last symptoms to remain after you've got better. So we know for Achilles injuries, we know that you're most likely to suffer with these when there's a change or a spike in training load. So when we're increasing your mileage for marathon training, will likely or could potentially overload your Achilles. Certainly we think probably anything exceeding an increase by 10% training load, the amount of volume of training you're doing, by increasing that by more than 10% per week puts you potentially into that. Obviously depends on how strong and how robust your Achilles is beforehand. So it could be potentially the first sign. So what I would say, things you can do, either you come and see someone and have a look and get a proper diagnosis, or alternatively you can ease up, rest for a little bit and see if it gets better. Not necessarily, I would say, wouldn't be recommending total rest, but relative rest, so doing slightly less than you're doing now. Maybe making sure you give yourself 48 hours between runs. We know that Achilles takes about 48 hours to produce an adaptive response to the training you had the day before. So probably looking at your training, probably getting a correct diagnosis. At Office Feet 99, why do my feet ache after standing at work all day, even though my shoes are supposedly orthopedic? Well, that's a difficult question to answer. So obviously, if you've been standing on your feet all day, people who do that are likely to have sore feet. All right, I think that's, it doesn't necessarily mean anything's wrong with them, but obviously they're tired, they're fatigued. That is obviously one reason. Orthopedic shoes. So just because shoes are orthopedic doesn't necessarily mean it suits you, it suits your foot shape, suits the properties of your foot, or even the job at hand, what you're actually asking your shoes to do for your job. How well your shoes fit, how well supported they are, might depend on that. A lot of orthopedic shoes either have some sort of arch support built into them, or they're made out of memory foam. A lot of them I see that are just made out of memory foam. In actual fact, I think memory foam for a lot of people, especially if they're walking around, is less good for their feet. It's not as good for their feet as more traditional shoes. And probably that might well be look at the shoes first of all. Look at the job. Look at your colleagues who are doing the same job. If you've all got sore feet, it might just be that it's the nature of your job. And if there's nothing pathologically wrong, you rest and it goes away quickly. So once you stop working, it settles back down again quickly. And I think it might not be the end of the world. All right. Jim Dad 40. Is it safe to keep training legs with plantar fasciitis? Or should I stop training completely until it settles? Now, this is a really good question. So in clinic, what I look, if we see patients with any sports injury really, I normally am keen for you to continue to exercise as much as you can. So we might get sports people in and we might modify their load. So we use something like relative rest. We call the term relative rest, which means we're reducing how much we're doing, but not stopping it altogether. All right. Now, the idea is you reduce your load to a point where it doesn't spike symptoms, and any increase in symptoms settles quickly. Then we're happy for you to carry on. But obviously, if it's taking too long for your symptoms to settle, or symptoms putting you in the red zone for making the injury worse, then I think obviously we'd have to consider reducing it. It's rare that I would stop someone from training altogether. Maybe we might adapt with your training. And modify the amount you're doing, or the intensity, or even how frequently you're doing it. There are ways around that as well, adding in things like orthosis and particular footwear types, recommended footwear that might enable you to do a little bit more and stay comfortable whilst offloading the plantar fascia. It's important to remember that plantar fasciitis is best treated with exercises. So there's an element of this we will be exercising anyway. At Ballerina Becca, what's the best way to strengthen my ankles after repeated strains? I'm scared of rolling them again. Now, this is obviously a common problem with a lot of sports people, not just ballerinas, but I presume Becca is a ballerina. Strengthening exercises is the best way. So things like physiotherapy would be a good way of doing that. And we often refer to physio for that sort of strengthening program, where progressively exposing someone to harder exercises as they become stronger. We know that rolling your ankle can leave you with a weakness, can be neuromuscular, and or it can be structural. Obviously being assessed for that is important, but probably following a strengthening rehab program, retraining some of the neuromuscular pathways would be the way to go. At Sunday Footballer, I get pain in the top of my foot after a match. Could this be a stress fracture, even if I can still walk on it? It's possible. So we think most people with stress fractures are still able to walk, and normally it's only the provocative activity that brings on their symptoms. So for example, someone might be strong enough, their stress response may be sufficiently strong for them to walk, but anything above walking, like running or jumping, would be exacerbate that. A couple of things with stress fractures, telltale signs, normally we call it crescendo sign of pain. So pain that doesn't hurt when you particularly start and builds to a point where you can no longer carry on. That's the crescendo. The other one I look for is pain that wakes you in the night. So not just stops you from sleeping, but it's actually waking you up. They're the two that I probably look for. As far as symptoms goes, there are also a lot of other reasons why the top of your foot could hurt, especially playing football. Again, probably seeing a foot specialist. So next one. Barefoot buzz. Do barefoot or minimalist shoes actually improve foot strength, or is it just social media hype? This is actually something I see. I get this question quite a lot, actually. There's a huge hype on social media for minimalist shoes, and my feed is always being filled with people trying to sell me minimalist shoes. In theory, if you can acclimatise yourself to wearing them gradually over a long period of time, I think was shown to take about 18 months to fully acclimatise to wearing these all the time. Potentially your foot could be stronger. All right. You have to ask yourself though, is that a good thing? I'm not always sure it is. I think certainly for some people, yes, potentially, and for a lot of people, certainly the ones realistic, the patients I'm going to see in clinic, probably not good candidates in the short to medium term. I'm probably not putting people in minimalist shoes to make them feel better. We're normally looking at patients that I see are injured. They have a weakness, something's torn, something's overloaded, something's strained, and we're all trying to offload that. Increasing that with minimalist shoe is probably exposing an injury, potentially making it worse. So normally it's not something I would normally advise people to go to, but probably looking at, if you were to do it, to gradually introduce it over a period of time. So drip feed approach, progressively exposing yourself as you get stronger, probably coupled with a bit of a strengthening foot program, so that you can you're doing some of the hard work as well, so it's not just left to your foot. I would say, I think there was a study that came out that showed that most people would want to transition them on average get injured once, the one injury per attempt to transition, which probably tells a story in itself. That step count queen, my smartwatch says I do 15,000 steps a day, but I'm still getting shin splints. What am I doing wrong? So shin splints is a difficult one, because shin splints is like a symptom. So like say I've got a headache, and obviously you can have different reasons for having a headache. And so we think there are a few different conditions that would cause shin splints. Shin splints mean shin pain. Most common one we probably see, certainly in runners, is medial tibial stress syndrome. Now, overload of the bone is one of the things that we believe is causative. So that's someone who increases their load too quickly. There are a lot of patients I see that almost really not increasing it by very much at all, if anything, and they're still getting shin pain. I think certainly in patients I see, there is definitely a commonality in gait patterns, biomechanic patterns that we see, and I look at that and I think a lot of that comes from proximal, so it comes from the hip and glute area, core strength. Patients that have increased Q angle, so that's the angle their thigh bone comes out, and certainly any valgus movement at the knee, where they become knock-kneed, put a bending force on the tibia, and that can be, I think that's, for my money, I think it's as causative as anything else, and that, obviously that's where you see the pronation of the foot come in. I'm not sure the pronation of the foot is, for a lot of people, causative in isolation. If you think you've got a increased Q angle, genovalgum, your foot's going to have to be pronated, otherwise it's not going to be plantar great. Walking on the outside of your foot, for example. That's an interesting one. And sometimes we thought we'd give them insoles, but probably looking at proximal strength control is probably the thing that I'm aiming for most patients I see with shin splints. What's the next one? So, mums on the go. Since having my second baby, I've had arch pain and flat feet. Will this go back to normal, or do I need insoles? I actually had this question yesterday, actually. So it's common that mums notice during pregnancy that the arch is lower, and that often the foot can increase in size. So there is a hormone called relaxin that flows through the body when you're getting ready to give birth. What it does, it loosens and makes all the ligaments in your body slightly more lax, enables you to pass the baby through the birth canal, but it works systemically. It's one of the reasons why women get a lot of sacroiliac joint pain, and carpal tunnel syndrome, and pelvic girdle pain. The feet do lower and can go back, and I would say that we would expect for most normal people, if we account for all of the other changes, that should go back. Having said that, doesn't always happen. Obviously, one thing happens a lot of women during pregnancy is they put on a fair bit of weight, so it's not uncommon for women to be significantly heavier at the end of pregnancy than they were at the beginning, and even after giving birth. The postnatal period, they're significantly heavier. That's obviously that force carrying the weight around is going to flatten the feet, and would do even without relaxin, but relaxin is probably just speeding that process up. Insoles, certainly in the medium term, can help patients be more comfortable, all right? Especially if they're getting pain from the flattening of their arches. And so not necessarily always a long-term solution, but could be a short-term solution that helps make the months and possibly first year after giving birth more comfortable. And if you don't have problems with your feet, don't worry too much. The trail treadmill. What's the difference between tight calves and restricted ankle mobility? They both sound the same. So I see patients who have been told elsewhere they have tight calves continually, and it's very difficult to unpick that. And what I mean by that is the sensation of tightness in the calves and there being some sort of ankle restriction because the calf is too tight, so it almost won't move anymore. And I think tight calves is overdiagnosed. We think we need about 10 degrees of ankle dorsiflexion, where ankle is the foot is coming towards you at the ankle. And we think that only about 10 degrees is all we need for normal function, normal movement. And I feel like patients who have that or have more than that are often diagnosed with tight calves and recommended to have stretches. What we think actually is that sensation is just a sensation. It's not a physical restriction. And that strengthening exercises are better served in those cases than stretches. Stretches help to relieve those symptoms in the short term, but do nothing to actually tackle the underlying cause. And for most people, the underlying cause is some sort of chronic fatigue to the muscle. We often see this in runners who don't do any strengthening exercises, but it can be a range of different sports people. The stretches relieve symptoms, but don't solve underlying cause. Tight, restrictive movement of the ankles can be from tight calf muscles, absolutely. It can be from other reasons as well, emanating from the joint and other parts. So sometimes that's, if you actually have a restricted ankle movement, we might be looking a bit more in depth at you, and in those cases, even stretches maybe serve no benefit to you anyway. At Coach Tom PT, how can I tell the difference between Achilles tendinopathy and a partial tear in my clients? Is imaging always needed? So, I would say that mid-substance tears of the Achilles and Achilles tendinopathy are a spectrum of the same problem. So you can obviously have an acute tear, an acute rupture, even sometimes in your Achilles, and that's an emergency. You probably know about it. It's normally sudden onset of pain and sudden loss of function. A lot of patients aren't completely functionless and actually compensate reasonably well, continue walking around with this, and I've certainly seen that before, and absolutely scans are needed in those cases. Normally we're thinking tendinopathy and patients who've been suffering for quite a while, and we're thinking partial tears as mid-substance tears. The degenerative changes in the tendon, and we can see them on scans. If we think they're chronic, wouldn't necessarily change the plan. We're still looking at strengthening exercises and the same treatment protocols as you would with a tendinopathy. I tend to scan them all, ultrasound scan, and point of care ultrasound in clinic with me everywhere I work. I would recommend scanning them all because I think it's the 21st century and we can, and so we probably should be making sure we know as best as we can rather than guessing. Having said that, not everyone has access to that, and sometimes clinical tests will give you an idea. There are clinical tests to do that, and so seeing an appropriately qualified person maybe I'll give you some good advice. Well, that's all the questions for today. So look, hope you like this. I don't know if you stayed and watched the whole thing. I want to try and do a few more of these. I quite like this sort of format of imparting information, and whenever I've done any teaching, I've liked the kind of seminar question and answer ways best rather than lectures. If you like this, click like and subscribe, and hopefully if I do it any more, which I hope to do regularly, you might get notified. If you have any other questions, what I'd like, put them in the comments for me, and I'll pick them up our next go around. Take care.